record this. Okay, we are recording.
Perfect. Hopefully that makes up for the delay, and hopefully people will be able to view this recording later because I'm sure there's a couple people on live Instagram right now wondering where we are.
Yes. Well, we will post an update and from now on, I guess, until we get 1,000 followers. So if you know anybody, follow our accounts and hopefully we can be back on Instagram Live shortly. We have
And what we can do maybe moving forward is just post a Zoom link instead of an Instagram link, and that way people can log in via live via Zoom. But do you want to kind of tell people what happened?
Yeah. So I started the Instagram live, tried to start the Instagram live like I always do. And today, of course, I get a message that says that I cannot start a live unless I have a public account, which I do, and have 1,000 followers or more. So that is what happened. So I couldn't even start a live, unfortunately. But this is another great alternative. Thank goodness we can jump on this quickly and still do this and still post it. And eventually these will also be on YouTube so you can rewatch them. But definitely the live component is nice because it's more interactive. But we will, like Dr. Paris said, we will post Zoom links in the near future until we can get to 1,000 followers.
Well, today's a big topic.
It sure is.
Yeah.
Yes. Okay. So, yeah, we're starting kind of a series. We can't cover everything in one episode because this is such a huge topic. And thank you for everyone that requested it because it's super important. And there's a lot of people in this age range right now that are looking for help and information and advice on perimenopause, which I really like, your you sort of threw out the term adolescence in reverse, right? So it's kind of puberty in reverse. So today I thought we could chat about how estrogen specifically, so and the decline of estrogen, what effects does it have on our system and what symptoms we can experience with that decline in estrogen. And we can kind of go back and forth based on our expertise. Um, there's kind of, I guess the biggest thing I'll ask you is what happens during perimenopause to estrogen?
Yeah, so I think the first thing I want to kind of clarify is that, I assume that women understand their hormones more than they truly do. And I don't mean that to be dismissive in any way. I just mean that because I don't think that they've ever really been taught. And so perimenopause is that period before menopause actually comes. And if we look at the medical definition of menopause, menopause is 12 full consecutive months without a menstrual period. But that perimenopausal period for some women can begin a full decade even before they start getting some changes in their cycles, or definitely even years before the period stops. So oftentimes, what I hear from patients is their doctor's like, well, you're just getting older and that's just the way it is. But I don't really like that answer because there's so many things that are taking place in a woman's body during that time. And the hormones can change from month to month. I think that's another piece that I really want to touch upon. Oftentimes, women will have blood work done, they'll have serum blood work for estrogen or progesterone or FSH or LH, and they look normal. And in that period of perimenopause, kind of like the way that we test blood sugar, those levels can be up and down all day long throughout the cycle. So they might be normal one day, but it's also very possible that they would come back abnormal another day. So I never rely on serum testing in that perimenopausal period because I personally think that it is a waste of money. Different story in postmenopause. But Estrogen has an effect on so many different parts of the body outside of the female uterus and outside of the female breast tissue. And again, this is something that we are oftentimes not taught as women by our teachers, by our mothers, or by our healthcare providers. So when all of these symptoms start coming up, women start to feel like they're kind of crazy, right? So definitely from the standpoint of reproductive hormones, we start to see, some changes in the menstrual cycle. So women may notice that their cycles are getting further and further apart. They may notice the opposite. They might notice that their cycles are getting closer and closer together. They might notice that they're skipping a cycle. They might notice that suddenly they're bleeding excessively, and then another cycle they're barely bleeding at all. So that's oftentimes the first thing that may alert women to the fact that there's something going on with their hormones, that they're entering into that perimenopausal period. The other thing, obviously, that is oftentimes overlooked is the impact of things like estrogen and progesterone on mental health. So we start to see things like insomnia, anxiety, depression. And the insomnia is not necessarily always mediated by hot flashes. There can be the hot flashes, there can be the night sweats, but because both progesterone and estrogen have a really calming effect on the nervous system, when we take those away, it's essentially like taking away the parking brake, and the nervous system can kind of begin to run a little bit wild.
Right. The
Um,
one, so like one of the, if we kind of break it down, so one change that happens during perimenopause is mood swings.
yeah,
And
absolutely.
so it sounds like the mood swings happen because the estrogen, that's this kind of like blanket and this, sort of soothing hormone, it gets depleted and it no longer is there to help us regulate our nervous system. And so
There's an
that,
intimate relationship between something called GABA, which is an inhibitory neurotransmitter, meaning it like puts the brakes on the runaway nervous system, and estrogen. And so when estrogen goes down, GABA also goes down, and so we don't have that brake. So women will say things like, I'm anxious for no reason. I'm waking up like there's an elephant on my chest. I'm freaking out at my family or my coworkers. And the odd thing that they'll say is that they're fully aware of the fact that they're doing it. They see themselves doing it, but they don't feel like they can actually stop. And so oftentimes, women will be prescribed things like SSRIs or anti-anxiety medications when really it's the fact that those hormones are going into decline and it's having a detrimental effect on their ability to regulate their nervous systems.
okay. So mood swings, check.
Mood
What,
swings.
okay. Next, let's talk about bone loss and how estrogen can affect bone loss and lead to potentially osteopenia, osteoporosis.
Absolutely. Definitely the two big things that we see from a metabolic standpoint after menopause is an increased rate of cardiovascular disease and a increase in osteopenia or osteoporosis. Why? Because estrogen is protective both to the heart and the cardiovascular system, but also to the bones. So metabolic changes for sure in the bones, cardiac changes without a doubt, and muscle loss is also a big one.
Right. So estrogen actually helps put more bone on, essentially. I'm trying for people that don't understand what osteopenia osteoporosis is and why estrogen affects it. It's kind of a building block for making more bone.
Yes.
And when it goes down, then we kind of lose the ability to regenerate bone and so the strength of the bone, the bone becomes more brittle
Absolutely.
or porous than it would be with a full supply of estrogen. Okay.
And I think something that kind of compounds that too, Luba, is the fact that we also start seeing things like weight gain in menopause, which is more mediated by estrogen's impact on insulin. And then we start to see the decrease in muscle mass. And that muscle is so unbelievably important. I can't stress that enough with my patients, that it's not about being ripped and having the body of your dreams. It's not about vanity at this point. It's about actually having strength, because the more muscle you have, two things are happening. The more muscle you have, the more pull there's going to be on tendons and ligaments, and the more that that bone is going to be forced to turn over. The other thing is that the more muscle you have, the more little mitochondria you have, which are those little energetic batteries inside the cells, which make us a lot more efficient at burning fuel. So, muscle is going to help with bone loss, but it's also going to help with keeping the weight off, because as we get more into menopause, many of us, depending on our genetic predispositions, become a lot more sensitive to the effects of carbohydrates. So we start to see the insulin resistance, we start to see the prediabetes happening.
So let's just again break it down real simple. So estrogen helps with the production of insulin.
So the lack of estrogen is going to lead to the insulin resistance. So kind
Insulin
of the
resistance.
other way around.
Right. Okay. Yeah. I was saying more and yeah. Okay. So lack of estrogen leads to insulin resistance, which means that when you eat, for every like gram of carb or sugar that we put in our body has to work harder, right? Our pancreas has to work harder to break it down and metabolize it.
Yes, and it's
Stores
also
it.
more likely to go into storage. So this is why, not that I espouse any particular diet, but this is why things like a carnivore diet or a low carb diet or a more keto friendly diet tends to work really well in that perimenopausal population, because it takes the insulin kind of out of the equation. So they're focusing a little bit more on a higher fat content,
Yeah.
if
Okay.
weight loss is a goal.
Right. Yes. Which I think it's really good that we're talking about because so many people have kind of the same questions, very similar symptoms, and and it's I hear the same thing over and over again. So these are the main things. The other thing that I hear about working where I work is changes with vaginal microbiome and lubrication and things like that, and sensation during intimacy. And on top of that, frequency, urgency, UTIs. Um, that the estrogen helps, and even prolapse symptoms. So estrogen helps keep the tissues robust in everywhere, right? But the pelvic floor is also muscles and ligaments and all the other things. And so when the tissue integrity decreases, um, then we have symptoms like vaginal dryness. We have symptoms like UTI because the urethra itself, the in sort of environment becomes more brittle and more susceptible to getting infections. Um, Prolapse, like somebody could have a prolapse right after delivery, and then through various means, usually not breathing properly with heavy lifting or things like that, the prolapse can kind of get worse, but people don't feel symptoms usually until perimenopause or menopause because their tissue degenerates to the point where they can actually feel a bulge, whereas before it was held up kind of by more robust tissue. Um, so anything to add to that?
No, I'm just kind of agreeing with you that definitely the prolapse and the UTIs and the yeast infections, again, all of that is mediated by those hormones, because there's the strength and the elasticity of the pelvic floor that's now become a lot more compromised. You combine that with the changes in the pH of the the vaginal canal, the microbiome is going to change. And then there is a bit more friction during intercourse because of how thin that membrane is and how dry it is. So UTIs sometimes are the most common symptom for women in menopause earlier on, because they might not necessarily be getting the hot flashes or the night sweats sweats or the mood swings, but they might realize, oh, like I feel like I get a UTI way more often now, or I've never had a UTI before, and now every time I have intercourse, I'm getting a UTI. So that's actually a pretty big, I don't say red flag necessarily, but that's a really good indicator that the hormones are beginning to change.
Yeah. And one more thing about estrogen and stress incontinence is estrogen helps keep the urethra stickier. I know I've said this before in other episodes, but
It's worth repeating though.
yeah, especially here, right? So the estrogen actually helps keep the urethra sticky. And when the estrogen decreases, that stickiness goes away a little bit. So when there's increased pressure, intra-abdominal pressure with a cough or a sneeze, that's what stress incontinence is. When there's increased pressure on the bladder and the urethra, there's a little bit of leakage. And so that happens more often when estrogen starts to decline because that stickiness of the urethra goes away. Yeah. So,
So with your patients, obviously you're doing a lot of pelvic floor work and a lot of re-education. Is there any particular tip that you would do differently with a woman in perimenopause? Is there a nugget that you would give them? I mean, obviously there's so many different things that we can talk about that we'll get into in next webinars, but is there something that you really, really focus on in that clientele?
yeah, so specifically for stress incontinence, we practice something called the knack, which is just um, it's a well-timed contraction. So I have them practice squeezing and then coughing so that their pelvic floor knows to do that when it's time to cough or sneeze in the wild, as we say. Um, but most of it is I just want to assess tissue and coordination of the pelvic floor because um, people come in when they're symptomatic, but I don't know how long they've they haven't had coordination, how long they've been disconnected from the pelvic floor. So a lot of my sessions, no, they're not that much different than what happens after delivery. It just it's just after delivery we can catch a lot of this stuff sooner and then prevent some of the issues that we would have later on in life. But by the time, people find me in their late 40s and 50s or whenever things start to kind of present themselves, then it's a different it's different and it's not different. We still work on pelvic floor coordination essentially. So I don't know if that answers the
No, it,
question,
it
but
definitely does. I know our work is somewhat different. So even though it's not a universal rule, there's certain factors that I see with my patients that can predispose them to having a metaphorically bumpier ride, for example, in menopause, right?
yeah.
I look at the adrenal health, I look at pregnenolone levels, we look at the thyroid because those hormones are always working together. And that's something that ideally we want to address and make sure those things are stable and good well before perimenopause happens. We're not always that fortunate depending on when we meet. I'm just kind of wondering the same thing for you. Is there anything for your women before they're entering into this perimenopausal period that you really want to educate them on if you have the opportunity to do so in advance?
Yeah, I mean a lot of it just really it's kind of like so the assessment is key because there's no other practitioner that can take a look at your pelvic floor function. And to give advice before assessing somebody is kind of like saying, like you and I are on a Zoom call and you say my ankle hurts. What do I do about it? But you can't look at it and you can't touch it and I can't measure it and I don't know the strength of it, but like tell me what to do for it. Like um it's hard to know whether or not somebody has a connection to that part of their body. And if they don't, that's going to lead to more issues. And that's the biggest thing that I give to my patients is the ability to connect mind and body and to understand their pelvic floor and understand strategies to prevent prolapse or at least not make it any worse. Um, I also work with other practitioners like yourself. We talk about possible, hormonal replacement, topical estrogen, things like that, to help. bring up the estrogen levels, even if it's very localized. And that's actually another question I have for you to throw it back is so there's a lot of talk about hormone replacement, right? Estrogen specifically. Now, this was a question posed to me to ask you during this call. Uh, when should somebody start hormone replacement and specifically for estrogen? Because there's some studies that show that one must start about 10 years before the onset of all these symptoms. And if you start kind of right when they start, then that might lead to some things that we don't want. Any thoughts on that or
Yeah, so I'd have to see what they're citing. The studies on HRT are kind of all over the map, right? So everywhere from talking about increased potential risk for heart attack and stroke to studies that are saying the exact opposite of that, which is to say that things like hormones, both estrogen alone, but also estrogen with progesterone, can decrease cardiovascular risk, can reduce the risk of a heart attack or stroke, and obviously prevent breast cancer by about 24%, I think is the last study that I read. So I don't know if I'm speaking clinically that I have ever had a woman start hormones 10 years in advance of going through full blown menopause. Typically, what I see clinically is that women are starting in the years leading up to the cessation of menstruation. I do think, though, that as a culture, we're getting a lot less afraid of the hormone replacement options, whether they're intravaginal, whether they're topical. And that is a place where I do find if a woman is supplementing, that measuring is actually really important. So we want those hormones at certain levels in order to ensure bone density and to ensure that it's having a positive impact on their cardiovascular system, on their mood. Obviously, they can tell things like their vaginal health a little bit easier than they can other areas. So 10 years to me does feel like a little bit of a stretch. I will also say full disclosure that while I use topical progesterone, topical estrogen, and intravaginal estrogen, DHA, and pregnenolone, I can't and don't prescribe bioidenticals. So I'm not the 100% expert on that.
okay. Well, still, I mean, really good information. I think even if it gets people's gears kind of turning and just to understand because there's so much going on, so it can be scary and it can be lonely. Um,
I
so
also think that the dose is so unbelievably individual for the woman. Lower dose is typically what we want to stick with as far as ameliorating symptoms. And I also don't want to forget about testosterone. I think that a lot of women are so afraid of using anything that's going to raise their testosterone, period, right? Because one of the things that can happen in menopause or perimenopause is as those levels of estrogen and progesterone decline, women may find some more testosterone like symptoms. They might experience more male pattern hair loss. They may also experience growing hairs where they don't want to grow hairs. And it doesn't necessarily mean that their testosterone is high. It means that vis a vis the estrogen. So if here's estrogen, progesterone, and here's testosterone, as the estrogen, progesterone go down, the testosterone gets to be expressed. But testosterone can make a huge impact not only in muscle building and therefore bone health, but really, really important for things like thinking, planning, decision making, a lot of that kind of higher executive functioning. So I don't want to poo poo the role that testosterone can also play. And the beauty of our physiology is that sometimes when women just start building some muscle, ironically, their testosterone will actually go up pretty substantially.
right. And we do need testosterone. We definitely do. I think there's a misconception that, you know, it's just for men or something like that. But yes, our levels are much lower, in females than the levels in men, but it's still a very necessary hormone. Um,
Absolutely. Typical women testosterone is around mid 20s to mid 30s, barring a PCOS type backdrop. Whereas a healthy male, note I say healthy and not average, is going to be closer to 700.
yeah.
So that's a huge discrepancy. But testosterone has a lot to do with physiological health, and it's not just about libido. So I want to kind of clear up that misconception for a lot of women who are like, I don't really care. I don't have a partner. It's not important to me at this phase of life. Testosterone and raising testosterone is still really, really, really valuable.
Right. For muscle gain and all that stuff. But that's an interesting point that you said because that's another big symptom that people talk about is hair loss and unwanted facial hairs and things like that. And that it has to do with not so much an increase in testosterone during perimenopause and menopause, but more so the balance of the two hormones.
Absolutely.
Fascinating.
And, the hair loss can be a couple different types. So, with more the testosterone driven, we see the male pattern hair loss. And sometimes this does seem to be somewhat genetic, where we start to see a little bit of thinning at the top and more at the lateral sides. That's where something like minoxidil, does relatively well, is because it blocks dihydrotestosterone in the follicle. But almost similarly to what women experience post pregnancy after labor and delivery, when those hormones are high, their hair is beautiful and it's lush and it's full. And then as there's that sudden drop in the estrogen and progesterone post labor and delivery, they start to lose hair. And of course, there's other factors here too, like deficiencies in iron and, labor and delivery blood loss, et cetera, et cetera, the stress of having a new baby. But essentially, that sudden drop of the hormones from high to low really affects the way that the hair follicle or the hair anchors into the follicle.
Yeah, very cool. Well, I think that's a lot of information for people to process. We will definitely do more videos on this. There's so many things to cover. We actually we have a list going and we like barely touched the surface of it. So there's so much more to touch on the subject. But for now, let us know if you have any specific questions regarding the information presented today or anything else that we, could cover in the future. And then again, please let's subscribe and what do you call it? Follow, yeah, follow. Follow us, and we can hopefully get that follower number up and be back on Instagram Lives. Because I think it's a nice way to have us all participate in these, and hopefully that can happen soon. So that's your homework. But thank you, Dr. Paris. Any closing thoughts?
No, no, I think today what I really wanted to do was give a really broad, excuse me, overview of what's going on in menopause. And hopefully, in our previous lives, we can touch upon some of those individual topics, whether it's the mood changes or the changes in weight or the changes in intimacy, with some more actionable steps as it comes down to lifestyle changes, maybe some nutritional changes, managing stress, and maybe even some basic nutraceuticals that people can consider and try. Obviously, very general because they're not my patients, so we'll keep it kind of brief and simple. But to have those actionable steps, those nuggets that they can walk away with to say, okay, I understand what's happening, which is really empowering. And now here's what I need to do about it, and here's why that's important.
Yeah, fantastic. All right. Thank you
All
so
right, Luba,
much.
thank you so much.
And
I'm glad we were able to make this happen.
me too.
All
Okay.
right, I'll talk
Let's
to you
do it
soon.
again. Okay. Bye-bye.
Bye.